Hello everyone. Today we will discuss about the tongue. Now first of all, we all know the tongue is actually a muscular organ situated in the floor of the mouth. It is basically associated with the functions like taste, speech, chewing, deglutination and the cleansing of the mouth. Now very important thing, the parts of the tongue. The tongue has basically three main parts, that is the root, tip and the body. The body basically comprises of the upper curved surface or the dorsum and the inferior surface confined to the oral part only. Now first of all, the root. The root of the tongue is basically attached to the styloid process and soft palate above and to the mandible and the hyoid bone below. Because of this attachment, we are not able to swallow the tongue itself. In between the mandible and the hyoid bone, it is basically related to the geniohyoid and the mylohyoid muscles. The tip of the tongue actually forms the anterior free end, which actually at rest lies behind the upper incisor teeth. Now next is the dorsum of the tongue. Basically it actually is convex in all the direction and basically divided into oral part, pharyngeal part and the small posterior most part. Now first of all, the oral part. The oral part is actually, or we can say it actually forms the anterior two-third portion of the tongue or the dorsum of the tongue. Now the oral or the papillary part of the tongue is actually placed on the floor of the mouth. Its margins are free and in contact with the gums and teeth. Just in front of the palatoglossal arch, each margin shows 4 to 5 vertical folds named as the foliate papilla. The superior surface of the oral part shows a median furrow and is basically covered with papilla, which makes it rough. The inferior surface is actually covered with a smooth mucous membrane, which shows a median fold known as the frenulum linguae. On either side of the frenulum, there is a prominence formed or produced by the deep lingual veins. More laterally, there is a fold known as the plica fimbrata, and that is basically directed forward and medially towards the tip of the tongue. Now next is the pharyngeal part or the posterior one-third part. Now this part is basically separated or divided from the oral part by a faint V-shaped groove known as the sulcus terminalis. The two limbs of the V meet at a median pit named as the foramen caecum. They run laterally and forwards up to the palatoglossal arches. The foramen caecum over here represents the site from which the thyroid diverticulum grows down into the embryo. The oral and the pharyngeal part of the tongue differ in the development, topography, structure and also in the functions as well. Now more about this is that, now this part basically lies behind the palatoglossal arches and the sulcus terminalis. Its posterior surface, sometimes known as the, or we can say it can be called as the base of the tongue. Now this basically forms the anterior wall of the oropharynx. The mucous membrane has no papilla in it, but has many lymphoid follicles that collectively constitute the lingual tonsils. Mucous glands are also present at this area. Now next part is the posterior most, or we can say the small posterior most part. Now this part of the tongue is actually connected to the epiglottis by three main folds of the mucous membrane. Now these are the median glossoepiglottic fold and the right and left lateral glossoepiglottic folds. On either side of the median fold, there is a depression known as the vallicula. The lateral folds actually separate the vallicula from the piriform fossa. The next is the applieds of this part. Now first of all, glossitis. Now what is glossitis? As we all know, it is basically the inflammation, or we can say the ulceration of the mouth cavity or the stomatitis, right? Now in certain anemias, the tongue becomes smooth due to the atrophication of the filiform papilla. The presence of a rich network of the lymphatics and the loose areolar tissue in the substance of the tongue is responsible for enormous swelling of the tongue in the acute glossitis. The tongue fills up the mouth cavity and then protrudes out of it. The undersurface of the tongue is a good site along with the bulbar conjunctiva for observation of the jaundice. Also, in the unconscious patient, the tongue may fall back and obstruct the air passages. So this can be prevented either by lying the patient on one side with head downwards, the tonsil position, or by keeping the tongue out mechanically. Okay, so you can either prevent the blockage of the air passage by lying the patient on one side with head down, the tonsil position, or by keeping the tongue out mechanically. Now very important thing, that is the Waldier's ring. Now this Waldier's tonsillar ring actually includes basically 4 tonsils, that is the adenoid tonsil, 2 tubal tonsil, 2 palatine tonsil, and the lingual tonsil. The lingual tonsil in the posterior 1/3 of the tongue basically forms the part of the Waldier ring at this part. Okay. Now next thing is about the papilla of the tongue, very important. Now these are the projections of the mucous membrane or corium, which actually gives the anterior 2/3 of the tongue its characteristic roughness. Okay. Now these are of the following 4 types. That is, first of all, valate or the circumvallate papilla. Now they are large in size, 1 to 2 mm in diameter, and are about 8 to 12 in number. They are actually situated immediately in front of the sulcus terminalis. Now each papilla is a cylindrical projection surrounded by a circular sulcus. The wall of the papilla has taste buds, remember. The fungiform papilla over here, as you can see in the tongue, are numerous near the tip and margins of the tongue, but some of them are also scattered over the dorsum. Now these are smaller than the actual valate papilla, but larger than the filiform papilla. Remember that the fungiform papilla are actually smaller than the valate papilla, but larger than the filiform papilla. Now each papilla consists of a narrow pedicel and a large rounded head. Now they are distinguished by their bright red color. Now next is the filiform papilla or the conical papilla. Now these papilla actually cover the presulcal area of the dorsum of the tongue and give it a characteristic velvety appearance. Now they are the smallest and most numerous of the lingual papilla. Now each is pointed and covered with keratin. The apex is often split into filamentous processes. Now next, last is the foliate papilla. The foliate papilla are present at the lateral border just in front of the circumvallate papilla. Now they are leaf shaped actually. Okay, now next is about the muscles of the tongue. Now a middle fibrous septum divides the tongue into right and left halves. Now each half actually contains 4 intrinsic and 4 extrinsic muscles. Now first we will talk about the intrinsic muscles. Now the intrinsic muscles actually occupy the upper part of the tongue and are attached to the submucous fibrous layer and to the median fibrous septum. They alter the shape of the tongue. Now over here we have 4 muscles, of course I told you before only. Now the 4 muscles are, first of all, the superior longitudinal muscle, inferior longitudinal muscle, transverse muscle, and the vertical muscle. Now first of all, the superior longitudinal one. Now it basically arises from the fibrous tissue deep to the mucous membrane on the dorsum of the tongue and the midline lingual septum. They basically pass longitudinally back from the tip of the tongue to its root posteriorly. It basically inserts into the overlying mucous membrane. The superior longitudinal muscle act to actually elevate the tip and the sides of the tongue superiorly. Now this shapes the tongue dorsum into a concavity and it shortens the tongue also. Now next is the inferior longitudinal muscle. Now this basically originates from the fibrous tissue beneath the mucous membrane, stretching from the tip of the tongue longitudinally back to the root of the tongue and the hyoid bone. They insert into the mucous membrane of the tongue dorsum. It lies between the, remember, 2 muscles, that is the genioglossus and the hypoglossal muscle. The inferior longitudinal muscle act to curl the tip of the tongue inferiorly. This makes the dorsum of the tongue convex in shape and shortens the tongue. So remember, the superior one was actually making the dorsum of the tongue concave, while the inferior one is actually making the dorsum of the tongue convex. Next is the transverse one. The transverse muscle lies as a sheet on either side of the midline in a plane that is deep to the superior longitudinal muscle but superficial to the genioglossus muscle. They actually runs transversely from their origin at the fibrous lingual septum to insert into the submucous fibrous tissue at the lateral margin of the tongue. Now the contraction of the transverse muscle acts to narrow and increase the thickness of the tongue. Now next is the vertical. Now the vertical muscle is found at the borders of the anterior part of the tongue and it makes the tongue broad. Now next is the extrinsic muscle. We have 4 extrinsic muscles also, that is the palatoglossus muscle, styloglossus muscle, hypoglossal and the genioglossus muscles. Now first of all, the extrinsic muscle connect the tongue to the mandible, via genioglossus, to the hyoid bone through the hyoglossus, to the styloid process via the styloglossus, and to the palate via the palatoglossus. Okay, now very important is the arterial supply of the tongue. Now the arterial supply is basically derived from the tortuous lingual artery, a branch of the external carotid artery. The root of the tongue is also supplied by the tonsillar artery, a branch of the facial artery, and ascending pharyngeal branch of the external carotid artery. The veins over here are the deep lingual vein, vena comitans, and the vena comitans accompanying the hypoglossal nerve. Now next is about the lymphatic drainage of the tongue. Now in the lymphatic drainage, the tip of the tongue actually drains bilaterally to the submental nodes. The right and the left half of the remaining part of the anterior two-thirds of the tongue drain unilaterally to the submandibular nodes. A few central lymphatics drain bilaterally to the deep cervical nodes. The posterior most part and the posterior one-third of the tongue drain bilaterally into the upper deep cervical lymph node, including the basically the jugulogastric node over here. Now lastly, the whole lymph finally drains to the jugulo-omohyoid node, and these are known as the lymph nodes of the tongue. Now next is the nerve supply of the tongue. Now first of all the motor nerves over here. All the intrinsic and the extrinsic muscle except the palatoglossus muscle are supplied by the hypoglossal nerve. The palatoglossus muscle over here is basically supplied by the cranial root of the accessory nerve through the pharyngeal plexus. So out of the 7 of the 8 muscles are actually supplied by the 12th cranial nerve. The next is the sensory nerve supply over here. The lingual nerve is the nerve of the general sensation, and the chora tympani is the nerve of the taste for the anterior two-thirds of the tongue except the valet papilla. The glossopharyngeal nerve is the nerve for the both general sensation and the taste for the posterior one-third of the tongue, including the circumvalet papilla. This was a very important part. The posterior most part of the tongue is supplied by the vagus nerve through the internal laryngeal branch. Now very important part, that is the hypoglossal nerve or the 12th cranial nerve. The hypoglossal nerve is the nerve of the muscle of the tongue. It basically leaves the cranial cavity through the anterior condylar or the hypoglossal canal. Now it basically courses lies between the internal jugular vein and the internal carotid artery in front of the vagus nerve. Lower down it basically curves forward to cross both internal and the external carotid arteries. It also crosses the loop of the lingual artery to lie on the hypoglossal muscle. Finally, that is a hypoglossal nerve, enters the substance of the tongue. It basically supplies 3 extrinsic muscle and all the 4 intrinsic muscle of the tongue. Now the applied aspects. Over here the carcinoma of the tongue is quite common. The affected side of the tongue is removed surgically. All the deep cervical nodes are also removed over here. Now over here we can say that the block dissection is basically done of the neck because recurrence of the malignant disease occurs in the lymph nodes. Carcinoma of the posterior one-third of the tongue is more dangerous due to the bilateral lymphatic spreads. The next is the sorbitrate. The sorbitrate is actually taken sublingually for immediate relief from the angina pectoris. It is absorbed fast because of the rich blood supply of the tongue and bypassing of the portal circulation. The genioglossus muscle is also known as the safety muscle. Very important Viva question. What is the safety muscle? That is the genioglossus muscle. The genioglossus muscle is also known as the safety muscle of the tongue because if this muscle is actually paralyzed, the tongue will fall back on the oropharynx and block the air passage. During the anesthesia, the tongue is actually pulled outward, or we can say forward, to clear the air passage. The genioglossus muscle is actually only muscle of the tongue which protrudes it forwards. Means this muscle actually causes the protrusion out of the tongue in the forward direction. Now it is basically used for testing the integrity of the hypoglossal nerve. The very important thing is that if the hypoglossal nerve of the right side is actually paralyzed, remember, if the hypoglossal nerve of the right side is paralyzed, the tongue on protrusion will deviate to the left side. Normal left genioglossus muscle will pull the base to the left side and apex will get pushed to the right side. Apex and the base lie at the opposite ends, remember. Now next is the transmission of the taste signal into the CNS, or we can say taste pathway. The taste from the anterior tooth of the tongue, except from the valid papilla, is carried by the chora tympani branch of the facial nerve till the geniculate ganglion. Okay, the central processes go to the tractus solitarius in the medulla. Now, the taste from the posterior 1/3 of the tongue, including the circumvalent papilla, is carried by the cranial nerve number 12 till the inferior ganglion. The central processes also reaches the tractus solitarius. Now, the taste from the posterior most part of the tongue and the epiglottis travels through the vagus nerve till the inferior ganglion of vagus nerve. Now, these central processes also reaches the tractus solitarius. Now, after a relay in the tractus solitarius, the solitariothalamic tract is formed, which becomes a part of the trigeminal lemniscus and reaches the posterior-ventromedial. Remember, posterior-ventromedial nucleus of the thalamus of the opposite side. Another relay here takes them to the lowest part of the post-central gyrus, which is actually the area for the main taste. Now over here, injury to any part of the pathway of the taste causes abnormality in the appreciation of the taste. Now the referred pain is basically felt in the ear in disease of the posterior part of the tongue, as 9th and 10th cranial nerves are the common supply to both of this region. So this was all about the tongue. I hope you understood well. Thank you so much.